All right, good morning, everyone. I'd like to go ahead and get started. We have a couple of housekeeping items first. The first, obviously, this is going to be broadcast live on Vimeo and YouTube. So please, if you have any questions, please use the microphones. The recording is live, will be available for viewing shortly after the presentation. And for our viewers, if you'd like to submit a question, one option is to text DeBakey, D-E-B-A-K-E-Y, to 37607. Submit your question and we'll try to get to that as well. We do have some upcoming meetings and training activities. The first one is cardiology for the non-cardiologist, which is on May 16th. And then we have pre-intern training for our vascular residents June 1st through the 3rd. Today is very special for me personally. Wilson Szeto is our grand round speaker this morning. So he was one of my mentors and primary persons that we worked with at Hospital of the University of Pennsylvania and Penn Presbyterian Hospital. Dr. Szeto is the chief of the Division of Cardiovascular Surgery at the Perelman School of Medicine at the University of Pennsylvania. He took over that job about 2 years ago. He's the Julian Johnson Second Professor of Surgery. He's a world expert in aortic surgery, minimally invasive mitral procedures, transcatheter therapies. He's an amazing teacher and an amazing friend. Wilson, thank you so much for coming. And he's going to talk to us today about the future of aortic arch interventions.
Thank you. So that might be my coffee.
Oh, that's your coffee. Sorry.
Well, Marvin, thank you very much. Those words were just incredibly too kind. I want to thank all of you for this opportunity to spend dinner with you last night. Thank you for that companionship. And certainly it's a privilege to be here to talk about aortic surgery, which is where it all started. And we'll talk about that in a few minutes to just get some historical perspective. And today I'd love to share with you, and obviously this is also a center of excellence when it comes to aortic surgery. So I want to kind of see this as an exchange information and conversation about where the current technology is and some of the techniques that's developed over the last decade or so in reference to the aortic arch. It's been sort of a black box to many of the surgeons. You know, we've done a lot of work in the distal aorta, done a lot of work in the proximal aorta, but I think the past decade there have been a lot of attention focus on the arch, and it's exciting to be found to really be able to talk about that. So here are my disclosures. So again, as a center here that is high volume aortic surgery, I'm sure you've seen anatomy such as this. These obviously are challenging anatomy to deal with. Complex mega aorta, both proximal arch and distal, and traditional, and still, these are challenging patients and anatomy to deal with. As all of you know, arch reconstruction has been around for about 2-3 decades. There are lots of things you can talk about it. You can talk about circulation management, brain perfusion and protection. For the purpose of the next 40 minutes or so, and because of this audience, I'm going to focus more on the technical advancements as well as some of the innovation of how we address and provide therapeutic options for this very challenging group of patients to manage. Back in 2022, and I'm not going to go into this in detail, but I just want to highlight a couple of points. This was a really interesting, important document. As you know, the AHACC guideline on the management of aortic disease was refreshed in 2022. And a couple of points I want to highlight, and I don't think this is lost to anyone here in this particular audience, but the first point I want to highlight is more and more recognition that to be a successful program, it's a team sport. And obviously this is a class of recommendation 1, and I truly embrace that. I really do think this is extremely important where we are today to provide the highest level of care for patients with aortic disease. Certainly here, as I mentioned, is not a surprise to anyone. I know you guys embrace that here. I see some friends here, of course, under the leadership of Dr. Lunston, Reardon, and Atkins. You have that spirit. So that's really, really nice to see as we continue to take care of these patients and innovate. Similarly, at Penn, we have also embraced this. I've been at Penn for a long, long time. I started my internship there in 1996 and got lost in Philadelphia, never left. And on the shoulders of giants of Joe Bavaria and Jeff Carpenter and Ron Fairman, we really did embrace and really have expanded our heart team as well. Under the leadership of Nimesh Desai, one of my partners, and Dr. Wong, the lead on the vascular surgery side, the Penn Aorta Center has really flourished, and you can see here we really do work hand in hand on a daily basis managing these patients. The second point about the guidelines, which we're going to get into, is for the first time there were actually some recommendations about the aortic arch. If you go back to some of the earlier versions, there were just not a whole lot. So I think this is the beginning of more and more innovation and evidence and science. And what I highlighted in red is highlighting the innovation. Frozen elephant trunks, stent grafts, hybrid procedures that are just near or just at the beginning, and in fact we're just building on this, and certainly not the end of the beginning. This is just the end of the beginning, not the beginning of the end. Over the last couple of decades, you can see here now, there have been multiple techniques. There are probably more techniques than I can represent on this slide, but we've gone from off-the-shelf usage of stent grafts for integrated deployment, sort of like the Be Safer technique that you guys do here. There are now frozen elephant trunks that have been designed for these type of procedures. We'll get into that. At Penn, before the advent of these procedures, we really have worked and investigated the benefit of a zone 2 arch with a concomitant or a sequential distal TVAR. And then at the end, I'm going to talk a little bit about the new device that is expecting FDA approval very soon, probably within a few months. That's the AUNDS device in the treatment of DeBakey type 1 dissections. That's a bare stent in the aortic arch for the management of DeBakey 1 with malperfusion. So really, really exciting stuff when it comes to technique and innovation. The European colleagues in STS, EAT-CTS and STS, recently had a guideline as well update. And I think this strikes the point even further. You can see here more and more science and more evidence demonstrating the benefit and the effects of frozen elephant trunks in all of these devices. I just wanted to show you this slide again, not to go through all the guidelines, but to really put it in the forefront that these technology has really made it from clinical trials to now practice. And I think that's really, really important. So to put things all into perspective, to understand and see where we're going, we always have to see where we started. And it's not lost to me that I'm standing here on the shoulders of giants. And of course, I have to pay some homage to what was started. This is not a specialty that's been around for a long time. If you really think about where cardiac surgery started, aortic surgery specifically was right here in Houston. And these are two of the biggest giants, as you know. And in 1952, they were the pioneers in aortic surgery and arch reconstruction. That's Dr. Cooley, obviously, and Dr. DeBakey. Interesting, early on, you can see their first 6 patients, mixed outcomes, as you would expect, they were pioneers, and a lot of infectious disease. They were all syphilis. We've come a long way in terms of treating both syphilis and aortic disease, but you can see here they were clearly the pioneer. Aortic arch surgery really didn't take off until we not only were able to adapt cardiopulmonary bypass, but really started to do advanced investigation and science on how to manage the brain. Just a brief comment, because there's a whole science and literature talking about brain perfusion and hypocirculatory arrest. But what I want to highlight, again, is the giant that Dr. Griep was with his work in Stanford and subsequently in New York, really being the pioneer on how to manage the circulation to the brain with circulatory arrest. You can see here his first report, deep hypothermic circulatory arrest at 14 degrees Celsius. Cerebral ischemic time was 43 minutes. That was the start of it. And of course, nowadays, we have come a long way with antegrade, cerebral perfusion, moderate hyperthermia, neuromodular, as well as pharmacologic protection of brain. It really, really was the beginning of how we can do these procedures, not only technically, but of course at the end of the procedure where a patient has intact neurologic function and be able to go home and function with normal quality of life. Now in terms of these mega aortas, all of you obviously are familiar with the elephant trunk procedure, and this was first described in the 80s out of Germany in Hanover, Dr. Bors. This was a stage 2 open approach where you had a proximal arch reconstruction, where a portion of the dacron was left in the distal aorta for a planned second stage open distal thoracoabdominal procedure. So 2 large open procedures. In concept and in practice, wonderful. But boy, when you talk about patient selection, and over the years, these are the series. Reasonable outcome, but look at the ends. They're not large series. We're not talking about thousands of patients, because patient selection for this sort of morbid procedure was challenging. These were often young patients, connective tissue disorders, and as our aging population is getting more and more prevalent, 70, 80-year-olds, most of us would agree that for a 70 or 80-year-old, something like this probably is not an option. And we need to think differently about how we can treat that growing population of patients. Well, in the 90s and 2000, we started to get into stent graft, and you're probably asking a question, well, what does this have to do with open arch surgery? And I think it was an aha moment for many of us who were involved with the endovascular treatment of thoracic aorta, that we thought we could perhaps come up with creative ways to marry open as well as endovascular technique. Endovascular surgery, as you know, has really changed the way we think about the management of thoracic aortic disease. When I was in training, a complicated type B dissection was done open. And that was a long operation, often in the middle of the night. Same thing with a trauma. Most of you probably haven't done an open transection in years, but that was the standard of care. This really did change the way we practice, because not only was it less morbid, the outcome was better. You were able to get a treatment, a seal, and patients were not paralyzed when they woke up, no blood loss. This was a really big step forward. With that, this group here as well, you can see Dr. Lunston here, Dr. Reardon here, really smart folks started thinking, asking the question, okay, we have this new tool. It was designed for aneurysms in a DTA, but is there a way for us to think about how to marriage these devices with conventional open surgery to have the same outcome, but perhaps lessen the morbidity and the mortality? And the whole field of hybrid surgery took off. And this center was a leader in that area. We as well started to think about differently how we do this. I can't believe this was 20 years ago. This is when I was an early young faculty. We presented our first 8 cases at the New York Symposium, and at that point, Dr. Griep was obviously the program chair, and it was a proof of principle. We could debranch the head vessels and treat the arch with a stent graft. Most of us don't do this operation anymore. This is a historical sort of journey for you to see how our technology has progressed, but this was a proof of principle. And the whole field, as I mentioned, of hybrid surgery took off. And you can go from simple debranching all the way to the left, and now more complex, as is a total arch, followed by a distal T-bar. And there was a whole new language that was developed. Landing zone, zone 0, 1, 2, and 3. Everything to you now that seems like normal language was all new to us in the early 2000s. Here are results. Again, these were patients we felt were not candidates for open surgery. We were able to demonstrate in our early experience that these can be done on or off pump with good mortality and morbidity. Less than 10% mortality, less than 10% stroke. Again, putting in the setting of these patients were not open surgical candidates. So again, another step forward, proof of principles that with innovation and some creativity, we can move this field forward with new ways to address and think about the treatment of these patients. Branch devices. I want to just talk briefly about branch device. Fast forward 20 years now with the Gore TBE device, the first branch device that's available in the United States. This center is also very familiar with that device. This was a monumental development for us as well, to have a branch device in the arch. Again, borrowing lessons learned before, we started thinking about how to set up the distal procedure, i.e. the Gore TBE, with a proximal operation that would facilitate that. In a pen, we had looked at some of the advantages of a arch that would be less technically demanding, meaning so in zone 2 as opposed to zone 3, leaving that left subclavian intact, but allowing now a landing zone in that background graft in the event in the future that a patient needs a extension and utilizing the benefit of a Gore TBE single branch to the left subclavian. And this has now become one of our options in the management of arch aneurysm and pathology. And this has obviously led to a whole industry excitement, partnering with physicians and surgeons about elephant trunks, or so-called frozen elephant trunks. So in contrast to the traditional elephant trunk that Dr. Borsk described in the 80s, where the elephant trunk portion of it is a traditional background graft, the elephant trunk portion now is a stented elephant trunk that has more memory and allows and facilitates a landing zone for the second stage of a TVAR as opposed to open surgery. So again, taking concepts of what we learned with open surgery, applying it to the new technology of endografting. So in the U.S., we were fortunate to have this device, the FloorFlex device, approved a few years ago. In contrast to our OUS partners, where there are a lot more options out there, this is our only device, at least currently, frozen elephant trunk approved in the United States commercial use. In this study, this IDE study was led by Joe Caselli here in Houston. Many of us were on this investigation. This device is obviously also available here in Methodist. Talking to Dr. Atkins, you guys are heavily working with this. The indications were both chronic in the setting of an aneurysm and dissection, as well as potentially for an acute DeBakey 1 or type A dissection. Can you help me advance? I think I'm frozen. There you go. Sorry about that. This is the primary group. There were two groups. The primary group obviously was the elective group. So put that into context. It was these results that has led to the FDA approval. 3% mortality at 30 days, 6% stroke, minimal paraplegia. And in the setting of these total arches, which traditionally have been associated with less than ideal outcomes, this was an eye-opening experience. Granted, this was a clinical trial in a highly selected setting. Nonetheless, it was a proof of principle that this device was another step forward. Partnering with Terumo, now that we have two commercially approved devices, meaning elephant trunk, frozen elephant trunk, and a distal endograft device, we wanted to study the concept of a partnership between open surgery and endovascular surgery. And this is the Extend Registry. Many centers, including ones here in Houston, are part of this study. This is, again, leveraging what we learned with open surgery, partnering and with less morbid distal endovascular treatment of thoracic aorta, as opposed to that traditional operation that was described in the 80s. Let me just show you some examples of how, in my opinion, this has really changed the way we think about management of patients with these tough anatomy. So this is a 44-year-old gentleman who had DeBakey 1 repair in 2020. He had your traditional ascending hemiarch. We'll talk a little bit about what are some limitations of a hemiarch reconstruction in this setting in a few minutes. But focusing on this redo setting, you can see here, as many of you have experienced, DANE, or distal inostomotic intraarterial arch, residual disease that needed treatment. We decided to treat this young man aggressively. He's 44. You can imagine here a redo arch. We went with a frozen elephant trunk. Discussion here of unilateral versus bilateral. Obviously, every center has their preferred technique. We tend, for longer circ arrest cases, we tend to go with bilateral integrated cerebral perfusion. We stay at a moderate hyperthermia. Depending on anatomy, so in zone 2, zone 3, and of course the plan was a distal TVAR. This is just a video of one of our early experiences. You can see here this device, that's the elephant portion of it. It's called frozen, is because it's meant to be placed antegrade during circulatory arrest, and also has a stent portion to it. I like to deploy this over a wire, especially in dissections, because I want to make sure the distal portion of that device is in a true lumen and not in the false lumen. And you can see here, this really is a nice advance from the off-the-shelf that we've been doing with antegrade TVAR, such as B-Safer, etc. This collar is then removed, and you'll see here very nicely there is a sewing cuff that is extremely facile and really does allow for an efficient hemostatic anastomosis. The deployment is completed by pulling the wire. The distal portion of the stent is deployed. You can't see it, obviously, because this is open, not fluoroscopy. And this is the cuff that I'm referring to. I'm in zone 3, and you can see here that collar really does facilitate a nice running anastomosis and quite hemostatic. It really is a nice advance and a very nice tool in the toolbox of a surgeon to address these difficult anatomies. And then once you're completed, you can go back on bypass through the perfusion limb, and then you can go on with the rest of your arch reconstruction with a stent now distal. This is a complete product. You can see here zone 3 arch vessels. You can see the residual hematoma. A few months later, the patient comes back. Instead of a big open thoracoabdominal incision, the patient is able to have a TVAR distally and have a really reasonable outcome, and the patient has done well since. In a more acute setting, I think this can also be an important tool for the surgeon. Certainly at a place such as here in Methodist, where you're a quaternary care center getting the toughest of the toughest aortic dissections from the community. This is a 42-year-old man, likely some sort of connective tissue disorder. He came in really sick. He had severe malperfusion. We're going to talk about this in a few minutes, about dissections and bad dissections from malperfusion. AKI, he had a root aneurysm. We wanted to be aggressive. Intraoperatively, 2 tear sites. One in zone 0 by the left main, and what really caught us by surprise was a second tear in zone 3 at the base of the left subclavian. Really challenging anatomy, where I think most of us in this room would agree that a traditional hemiarch probably would not be the right operation for this 44-year-old, especially presenting with malperfusion. Valve-sparing root, zone 3 arch. It was a very nice repair, definitive approach for this 44-year-old gentleman. Sure enough, likely connective tissue disorder or some sort of genetic aortopathy. On a year follow-up, he has now distal progression of disease. And again, this points to the fact that this is a very nice platform for allow us to extend treatment endovascularly without a big open operation. And this is the second stage procedure about a year out. You can see here with the elephant trunk portion way in zone 3, zone 4, you don't have to worry about getting that relay up over the arch. You can see here deployment within the elephant trunk portion and a really nice outcome without a big open second stage operation. And here's the completion CAT scan. So far in the interim analysis of the registry and the studies completed, we have now over 300 patients. And hopefully we can get that abstract together for the STS that's upcoming January. But at least on the interim analysis in 263 patients, again, this is a real-world, all-comers registry. This is not a prospective IDE clinical trial because both of these devices are commercially approved. So in the hands of surgeons in a real-world scenario, without strict inclusion-exclusion criteria, I think these results speaks for themselves. 3% mortality at 30 days, stroke less than 5%, paraplegia less than 4%. It really has demonstrated how far we've come in this field, not only as surgeons with improved techniques, but how innovation and technology has really empowered a surgeon to provide a better outcome for these patients that are presenting extremis. More technology. I think that's a theme. Surgeons like toys. We always like to do things differently, improve. We want to challenge ourselves. One of the conversation in terms of management of arch, at least from a heart surgeon's perspective, is often how challenging, especially you imagine in Texas, people are big, how deep that left chest is to get to the left subclavian. Most of the time, I think a experienced aortic surgeon can get to zone 3 in left subclavian, but occasionally you're going to have a challenge because it is deep in the chest, it's a redo, and you can't see. Obviously, there are different anatomies in the arch. Most of the time, as I mentioned, this is a case where if you took your time, protect the brain, you really can expose, and surgery is all about exposure, or you can get it out. Zone 3, you put some stay sutures on it, you pull up in zone 2, you see the left subclavian, you see the 2 other head vessels, you see the recurrent nerve. You can really do a good job taking care of this and doing a really definitive operation in zone 3. But that's not always all the time. And you can see here, this is, once you set this up right, so on anastomosis with good exposure, like everything in surgery is all about exposure, you can do this well. But occasionally you just can't. And there are a couple of new technologies that are coming out that I like to share with you that are under investigation, how to manage the left subclavian. So this is an adjunct technique or technology to help us manage the arch with these elephant devices. This is a device by, Terumo Aortic. It's called a Rapid Link. You can see here it's a hybrid device, much like the Gore hybrid device before it was removed from the market. It allows us to deploy this device distally in the left subclavian, and then having, instead of hand sewing it, and then allowing us to do the proximal anastomosis more in a more ideal setting. Again, this is more like a hybrid device where the Rapid Link is deploying the end target vessel. You pull it, deployment process, it deploys, and then the proximal portion of it is a Dacron graft with a variable amount of length that you can tailor to the arch operation you do. This is another device that I've been working on for almost 2 years now. It is a vascular connector. We've done the work in this for about 5 years. We started doing this work out in the animals out in the Bay Area. This device is called a Duet. We did our first in-human case Valentine's Day, now 2 years ago. I'm going to show you a video with the concept of it, and I think it's a pretty neat concept. You can see here, this is a vascular connector. I want to be careful with words because FDA will think differently if I call it a stent. So it's a vascular connector. Has markers on it. The black portion is the mid portion of the marker. And the idea here is that this is a device you insert into your target vessel through your graft so that once deployed, your anastomosis is done. So hence a connector. It's not a hybrid device, it's a connector. And when you're done, you're done. There's no more sewing. So the concept here again, that this allows us to do a vascular anastomosis quickly, especially in a deep chest, i.e. left subclavian. So this gives you an idea. There are multiple ways in doing this. I'm sure creative surgeons will think of a faster, a more efficient way to do it than I did. But you can see here, literally it is a connector that takes less than a minute to deploy. Okay, very, very interesting. So we did our first few cases, and I'll share this with you. This is one of our earlier cases. Typical case you would expect. DeBakey 1, repair, Dane, chronic aneurysm, 68-year-old, large distal arch, needs an arch operation. We did our typical zone 3 arch reconstruction, but for our anastomosis, we put a connector in the left subclavian and a connector in the carotid, hence really shortening our cerebral ischemia time. You can see here on the left, I'm going to play this. Once the distal anastomosis is performed, the connector is placed through the target vessel within your proximal Dacron graft. Literally, it's pulling that button on the end user side, and the anastomosis is done. Now, I do put stay sutures to bring them together because it can get a little bit wonky because this is an early first generation device that still needs some work, but I do put a stay suture at 3 o'clock and 9 o'clock bring the target vessel into the dacron graft so they're together. I have my assistant pull it up, and then I deploy. And then I do the same thing for the left carotid. You can see this here on the right side of the screen. You can see the device between the dacron graft and the left carotid. I pull up on the stay sutures. My assistant's helping me to hold that in place, and here I am pulling that lever, blue lever, deploy, tie those 2 knots, we're done. A minute, probably. It's a really neat device. This is the completion CT scan with a frozen elephant trunk here, Floraflex. Looks really, really nice. Patency, and here's some early out. We're completing, we've done 20 patients. We're looking forward to finishing the study and hopefully present it in the near future and hopefully FDA approval. So again, exciting stuff, innovation. Again, the spirit of what's here in Houston with Dr. DeBakey, the giants in the past, really pushing and challenging ourselves with not only technique, but embracing technology. And here are the sites here. And then finally, I think all of you may or may not be aware of this new elephant trunk device that's coming on, and this will be a clinical trial as well. That trial actually has started. The partner is Artivion. Now this is a branch elephant trunk device with a branch to the left subclavian. I like to think of this as an open deployment of a Gore TBE. That's what this is. It's an open DBE. Excuse me. This device will deploy during circulatory arrest in the distal aorta. You place that left subclavian branch in the left subclavian, and then you do your anastomosis in zone 2. More to come on this. This is a clinical, I just got started. They're limited experience, but so far it's been encouraging. To finish up, I'm just going to briefly talk about DeBakey 1 dissections in an acute setting. I alluded to this earlier about how the life-saving operation that we've been doing for 2 decades have changed the lives of many patients. But again, on the theme of getting better, I think we all understand some of the limitations of a traditional hemiarch, specifically distal anastomotic aortic entry tear. So as I mentioned, what are remaining challenges in this DeBakey type 1 population? And as all of you know, our mortality in this group remains soberingly high. The IRAD database, 30-day mortality is still hovering around 18 to 20%. So that we really have not made any forward progress in terms of that. The populations that are most concerning are 1, the patients who present with malperfusion. In some series, malperfusion is still associated with almost a 40% mortality. As I mentioned, the distal and anastomotic new entry tear concept, DANE, has really come to the forefront, that we are now asking the question, is there an upfront prevention or intervention at the index operation that we can impart? That would have the benefit of decreasing DANE, hopefully impacting positive aortic remodeling, and perhaps decreasing distal reoperation and perhaps survival. As all of you know, all the series that's been reported in DeBakey type 1 dissection, no matter what you do, total arches, hemiarches, the 10-year survival is soberingly at 50%. We really have not moved the needle in terms of making these patients live longer. Some of it is technique, some of it is patient disease. These are 6 patients. And we recently did an STS analysis of adult cardiac surgical database. Not a surprise to anybody, malperfusion is bad, and if you have to do a total arch, outcomes are worse. I don't think anyone in this room will be surprised by that. It's an observation that's very obvious to everyone. The more complex operation you do in the sicker population, i.e. malperfusion, patients are just going to be very challenging to take care of. This is a device that I have had the privilege of studying and investigating as a US IDE study. It's called an AMNDS device. And the idea here is to provide a tool to all the surgeons to perhaps to improve the outcome in a very tough situation. And this device is really not only designed for aortic experts, such as everyone in this room, but to really empower every single cardiac surgeon when they are tasked with this tough population at 2 in the morning in the middle of South Dakota, where you're just alone and you have a patient who's really, really sick. And allowing the surgeon to do an operation he or she is comfortable with, hemiarch, but a device to help address malperfusion. This device, and I'll share some outcomes with you, was recently approved HDE status in December of 2024, and we're expecting full PMA approval, hopefully within a couple of months. It's a pretty elegant design. It's deploy antegrader and circulatory arrest, much like an elephant trunk, but is deployed in zone 0. You do not need to do a total arch. This is a hemi-arch reconstruction. And you can see here, again, deploy doing the antegrade, but allowing every surgeon who's comfortable doing a hemi-arch to do this without changing their conduct of operation. The mode of action is such as you can see here. The proximal anastomosis is it's a robust one. It allows you to do it with a very low incidence of DANE. It opens up and stabilizes the true lumen, hence correcting malperfusion. And we think we have some data that this also may impact aortic remodeling distally in a positive fashion. More to come on that. But it was really the malperfusion piece that has us and the FDA very, very interested in this device. This data was presented in SDS back in 2024, the 30-day data, and the 1-year data we presented in 25 that has led to the IDA to approve it as an HDE, and soon, hopefully, PMA. This is a sick group of patients. This is DeBakey 1 with malperfusion. You had to have malperfusion to get in the study, clinical or radiographic. The majority of patients, 80%, had clinical, so it was not mostly radiographic. But you can notice here almost 40% of these patients have visceral malperfusion. And over half, almost 60%, have multiple beds of malperfusion. This is as sick as it gets. These are really, really sick patients. And in the SDS Adult Cardiac Surgical Database, you're expecting a 30% mortality. As you would expect, because of the design, no significant addition to the deployment time. Deployment time 4 minutes, implant time 15 minutes, and in this study, circulatory arrest time of 28 minutes. It really does not alter the operation that most surgeons are comfortable with, a hemi-arch. And I think that's the beauty of this innovation, right? Innovation for the few is nice. Innovation that empowers the many will really move a field forward. And that's what I'm most excited about this technology. This was the money slide. This really blew our socks away, and I think the FDA as well. It met both our primary endpoints. The total number of patients with greater than or equal to 1 major adverse event, and they were mortality, stroke, renal failure, myocardial infarction was 28%. The goal was less than 40, based on a reference cohort. We did not see a single DANE, and in the literature it was up to 30 to 40%. Not powered, but equally impressive, was that the mortality at 30 days was 9.7%. This is really impressive. Again, put it into context, acute DeBakey 1 malperfusion. This was eye-opening for us, and hence the moving forward, a very quick approval process. It was almost unethical, in my opinion, to withhold this from surgeons and patients. The 1-year outcome was also encouraging. All the benefits sustained over a year, and we started to see some benefits of aortic remodeling. One of these patients is actually out 2 years, and you can see here over time, the distal aorta in zone 3 and 4, as well as 1 and 2, have remodeled nicely, where most of your pathology now in more downstream, 4, 5, and 6. As you can imagine, total stabilization of the aorta in the arch, zone 0, 1, and 2, and fairly encouraging false lumen thrombosis in this remodeling as well. So very, very encouraging. Again, only 1 to 2 year data, more to come, but also potentially another benefit of this device in addition to treating malperfusion. Well, I have to finish up and, of course, just mention briefly, this is all here. You guys have been a major contributor to this field. Endovascular therapy of the arch is no doubt here. There are many, many devices out there. There's one now that's approved. That's the Gore TBE. Zone 2, Zone 1. This is now commercial. I remember when this was just in clinical studies. The next device likely to get FDA approval will be the Nexus device, a single branch device, you can see here. And there are already discussions about a next trial that we're very excited about. That's the double and the triple branch device, OUS, In Europe, the triple branch device as well as the double branch device have had tremendous outcomes with stroke of 5% or less. We are really moving forward with this type of therapy for the right patients. And Dr. Reardon, your group here was also instrumental in the GORE ascending ARISE early feasibility study. As you know, ARISE 1, 2, and 3 are ongoing. Endobentals are coming. This field is really moving forward quickly, and I'm so excited about the innovation. And I think this field is going to be very different in just 5 to 10 years. So again, I want to thank all of you for your attention. It is certainly a privilege and an honor for me to be speaking at the DeBakey Grand Rounds here in Methodist, where it all started. And it's certainly an honor for me to provide this presentation, and I hope that we can have some conversations from this point forward. So thank you very much. Thank you.
Do we have any questions out there? I know I've got 1,000. I guess let me just start out then. The group at Emory, when they've had patients that have come in with clinical malperfusion, markedly elevated lactates, really sick patients with DeBakey type 1 dissections and visceral malperfusion, have started treating those patients with a distal first strategy of where they'll go in and TVAR the descending aorta, and then come back once the patient's lactate stabilizes, they're clinically better, come back and do the proximal operation. How are you handling now those similar patients that we now have AMDS? Are you taking that patient with severe elevated lactates and going straight to the OR? Are you doing anything distally to kind of stabilize that patient before they undergo a massive proximal operation?
Yeah, great question, and it's an evolution. That's the first point I want to make. The second point I want to make is obviously it's at the judgment of the clinical expertise at a treating center. And then the third point I want to make is not all malperfusion is the same. There's DeBakey ones with malperfusion, and then there's DeBakey one with really bad malperfusion. Kind of like shock. There's shock and there's really bad cardiogenic shock. At least at Penn, we have a nuanced approach. We are, to be honest, still more towards a central repair first approach. We still believe in that. We centrally cannulate the ascending aorta due to case. Our concept is that you have to get flow in the true limit. Now, we're really end-stage malperfusion viscerally, meaning dead gut, peritonitis. You know, those we have gone with the Emory, Michigan approach as some sort of distal intervention. But other than that, most of the time we're fairly aggressive with going to OR first, getting into the true lumen, either centrally or adjunct, cannulating the malperfused distal organ, i.e. if you have a cold leg, we'll cannulate the aorta and the cold leg, and just get on pump and open up that true lumen. And do the operation we need to do in the arch. The AMDS device has really opened our eyes about that particular population. You saw on the slide, despite a 40% incidence of visceral malperfusion in that patient cohort, mortality was less than 10%. Yes, it's a clinical trial, artificial setting, I get all of that. But boy, with that new tool, we are even more affirm of a central approach, unless it's end-stage visceral malperfusion. And we've taken that role, or taken that posture as well with cerebral malperfusion. You have to be herniating for us not to operate, especially in a young patient. You know, on and off ultramental status, we're fairly aggressive.
I think Alan's got a question.
Yeah. Well, first of all, thank you for coming. Ann has just led this field, and sorry I missed the middle of that.
The operating room, but I got a dozen questions, but I'm always looking to say, what do we have that uniquely differentiates our center that we can contribute to this field? And, you know, the group of cardiologists here, one of the things that we have is an incredible group of cardiologists in imaging. And the imaging, cardiovascular imaging belongs inside the Heart and Vascular Center here. That's different from most places. I'm interested in how it's set up at Penn. And so I will say dynamic imaging for a dynamic process. I don't believe in static CT scans to evaluate a false lumen or flow patterns. And I think that looking at 4D flow and MRI, potentially along with CT scans, and then the new CT scan. You and I are in an imaging-based specialty. You diagnose these aneurysms in dissection with a CAT scan, and we follow them with CAT scans. The more we are involved in the understanding the nature of 3D imaging and 4D imaging, the better. And so where do you think, in terms of choosing the intervention, dynamic imaging should play a role? That's question number one. Question number two, let's give you, is that obviously you never know when you're going to need to switch from an open to an endovascular approach. The problem is that we started off moving the type A's into a hybrid room, and then we found out we hardly ever used the hybrid room. And so you blocked an expensive space for 12 hours. And is there ways of choosing the patients selectively where we don't tie one hand behind their back? You're talking about putting beer stents in the arch. I presume you're doing that blind. And I think there's fundamentally a problem with doing that will come back to bite you at some point in time. So the role of the hybrid room in type A dissections, and then dynamic imaging and evaluating and understanding what happens with these patients.
Well, thank you for those great questions, and you're absolutely right. This center has been a leader in imaging. We've learned from you guys quite a bit. Dynamic imaging is something that we've started to dabble in. Darren Schneider and I have worked quite a bit in that aspect and working with our cardiology colleagues. Now, obviously, in the setting of an acute dissection, we're not quite ready to get there with a 4D MR, but we work with our cardiology and our anesthesia colleagues using IVUS, vascular surgery, and our TE. Our cardiologists, our cardiac anesthesiologists are very, very attuned to imaging. So we use a lot of TE, even in the distal aorta, because they can help us identify wiring a true lumen, what does the false lumen flow look like, etc. Your second question is an interesting one, because we early on also did started gravitating to doing many of these procedures in the hybrid room. And we just felt like 9 times out of 10, you didn't need it. But that one time you do, boy, you're glad you were in there. So I don't have a really good answer for you other than experience and perhaps really thinking about that population of patients that could potentially benefit that hybrid room. And for us, it's the malperfusion patients. Your clinical malperfusion, not radiographic so much, but someone comes in with a cold leg or a stroke, where we really think we're going to have to do more than just either a zone 2 or a HEMI. Those are the ones that we push into the hybrid room. And of course, there's logistics. If this is 2 PM, forget it. If it was a weekend, night, yes. And again, this has to obviously go with healthcare, rationing and resources, unfortunately. But I think you're bringing some really good questions. And something that the technology that I'm not familiar with, but I know Darren is extremely interested in it, and you would be a content expert. Darren Schneider is the chief of vascular at Penn, by the way, FORCE. Is there going to be potential use of FORCE in these type of pathology? I don't know, but he's very excited about FORCE in distal vascular interventions. And we have access to FORCE at Penn.
Next question I was going to ask for you is the role of genetic testing. So we're having a lot of patients that don't specifically have an obvious family history, obviously have features of a connective tissue disorder, but they're coming in with an aortic pathology, don't really have hypertension, don't really have some other kind of inciting factor as the reason of why they have the aortic event going on. We're finding more and more of these patients have some type of genetic cause as the reason for their neuropathy. How do you think the role of all these new endovascular devices that in general are contraindicated in the use of connective tissue patients because of their outward radial force, how do you put that all kind of together in the management of these patients acutely? And then
That's a great question too. And similar to your center, it's an aortic team approach. We have medical geneticists, cardiologists that are interested in that type of work embedded in our clinic. So when we see patients, especially young patients or anybody who wishes to be screened for it, there is a very easy, robust way of screening. I can't keep up with all the different genetic aortopathy and the thresholds. If you read the guidelines, there must be 20, 30 of them. So I really rely on my geneticists to say, hey, this guy's threshold for surgery is 4.5, not 5. I just can't keep track of it. And I think it speaks a lot about working as a team and using all the resources you have. In terms of your second question about innovation, we'll have to figure out as we go along. In general, I'm less concerned about endovascular treatment when you're landing in a surgical graft, as you know. So in younger patients, I think a open proximal procedure followed by a distal endovascular approach is a very good one because you're landing into surgical grafts. You have to follow your distal landing zone, but I think that's where we start. Having these branch devices into the zone 0 in a genetic aortopathy patient probably is not where we should be going. So I would be concerned with, for example, a Nexus or Gore TBE in zone 0 in a 30-year-old Marfan's. I think that patient probably should, not probably, that patient should get an open arch and potentially a platform for a distal TVAR in the future.
Since you brought it up, I was going to, at the end of this talk, I'm going to show you what we've created here through NMed, an actual device app for your phone.
Wow.
And a website for all of the different genetic aortic conditions and
Great.
thresholds and all that. So you'll have that as a hands-on tool in the office.
That's great. Kind of like Vinny Bapot with the Valve and Valve app, right? I can't keep track of it. I really can't. And I think that's good because now all these patients are coming in very, very well evaluated, well informed about their particular risks. And as you know, we have to move away from just size. You know, right now, everything is threshold for surgery is diameter. We need to work on biomarkers. There are so many other things that we need to work on. But right now, what we have is just size and family history.
Yeah, let me ask, this may tee it up for his question, is, again, coming back to what do we have? In the original studies going around, the further around the aortic arch you go, the higher the stroke rate. I'm glad to see Nexus is down to 5%. I don't know why.
I don't understand it either, but it's impressive.
It's impressive if it's real. And so one of the problems is that here, we can do transcranial Doppler monitoring. We have the world's expert in transcranial Doppler monitoring. I think of that as dynamic imaging, okay? The problem is you take these patients in the operating room, you put them to sleep, they wake up, they've got a stroke. And you'll hear this at M&M all the time. Oh, it could have happened here. It could have been air. It could have been when we cannulated the nominator of the carotid. They have no clue when it actually happened. And if the Nexus guys have solved this problem, then they've figured out what the embologenic components of the stent graft actually are. But I don't think you're going to solve this problem until you have some sort of dynamic imaging of what's going on in the brain. And it can tell you about flow, and it can tell you about embolization. Is this the question you're going to ask?
No, but one comment, one question. So thank you for presenting today. Maham Rahimi, one of the vascular surgeons here. Recently with Dr. Reardon, we published a paper to look into see if we can come up with a scoring system for this type A aortic dissection coming in with a malperfusion syndrome. And we divided into clinical presentation, imaging, and also laboratory finding. Clinical presentation coming in with the nausea, abdominal pain, imaging, TEE images plus the CT scan, because this is an acute problem. Dynamic imaging takes time, but we're probably going to get there at some point. So I think with that scoring system, we can categorize vascular first or cardiac first. By these devices, it's a combination of cardiovascular first, but defining what that malperfusion is and how fast we need to address the malperfusion before the ascending. That's comment. The question is, I was just asking the quick dissection tool that we have, how often have we seen visceral aortic occlusion putting that bare metal stent in there? With the AMDS device, how concerned are you with occluding the great vessels and trying to salvage that, or have you seen that in the trial?
Great question. So with the AMDS device, and I'll get back to Alan's question, the recommendation is to deploy that device without a wire, which at first I was nervous about. But in 93 patients, and again, you're talking about expert centers, every device has been deployed in the true limit. And again, this is acute, not chronic. But I certainly would not argue against an investigator putting up a wire to deploy this if that's what they're comfortable with. 80%, 90%, remember correctly, were deployed without a wire. So that's the one, but I am concerned sometimes you can get into false, and I'm sure it will. It'll never be a zero incidence. You were just talking about expert hands. Now, in terms of your question about patency and occlusion, at least in the arch vessels, there has not been any reported occlusion of the arch vessels. However, what we did learn is that like any new tool, if you use it in the wrong indication, it doesn't work. So what I didn't mention here is anatomically, This device only works well as intended if there is no tear in zone 1 or 2. This has to be a zone 0 tear. If you have zone 1 or zone 2 or zone 3 tear, you need to do a frozen element truck. In the 4 patients that in retrospect, there was a zone 1 and 2 tear, and again, this goes to Alan's point about dynamic versus static imaging, they were not recognized. All of those patients developed complications. Not Dane, but pseudoaneurysms and persistent dissection in arch vessels. So I think you're absolutely right. Now, in terms of stroke, I want to keep this as a conversation. I'm always happy to admit when I'm wrong. I came out of the gate saying all these tunnels have to be antegrade. The brain cannot, survive with the metabolic demand it has without these tunnels antegrade. I think one of the reasons why I think we're seeing lower rates for stroke with the Nexus device is these are retrograde tunnels. Working with Darren Schneider now with his Cook IDE, I'm sure you guys know, he is doing some of these, all 3 branches retrograde, all from the groin. And as I think about this, early on, I was a big proponent that it has to be antegrade, and that was the Terumo double branch device, and that has been on hold and redesigned because they were both antegrade tunnels with a very higher stroke rate. I think there is something about that retrograde tunnel that provides embolic protection. Maybe not a structural, but physiologic embolic protection. And what I mean by that is, by definition, you're filling in diastole, right? It's a retrograde. If you're thinking like the heart and the blood, if it's a retrograde tunnel, it's a diastolic filling of the branches.